Hello, everyone, and welcome to this AnaBios webinar presentation. My name is Chris Mathis. I'm the Chief Commercial Officer at AnaBios, and it'll be my pleasure to introduce our speaker today and moderate this session. I'm very thankful for the opportunity to be providing this webinar during Thanksgiving week here in the United States, and especially during this year of conferences being canceled and so forth. And it's just been a great opportunity for AnaBios to bring people together in this virtual forum, which is live now. So before I introduce our speaker, I'd like to tell you a little bit about AnaBios. For those of you that don't know us, AnaBios is a unique contract research organization and biotech company based in San Diego, California. We recover human organs from ethically consented donors and use the tissues or cells to conduct physiological assays in which we can test preclinical compounds for drug discovery projects. We've essentially redefined first in human. So in other words, working with AnaBios is as close as you can get to a clinical trial without actually doing a clinical trial. So our speaker today is Dr. Catherine Cahill. She is the director of a pain and addiction lab at UCLA in California. She trained as an opioid neuropharmacologist at Dalhousie University in Canada and received her PhD in 1996. She was recruited to the Department of Anesthesiology and Preoperative Care at the University of California, Irvine in 2012 from Queen's University in Canada, where she had held a Canada Research Chair in chronic pain for 10 years. Catherine moved to UCLA in 2017 and is now a professor in the Department of Psychiatry and Biobehavioral Sciences and a member of the Haddo Center for Neuropharmacology at UCLA. She has more than 25 years experience in research that focus on understanding mechanisms of chronic pain and opioid analgesia, tolerance, dependence, and addiction. Her research spans both basic science and human research, which focuses on how chronic pain states modulate reward circuitry and changes dopaminergic transmission responsible for motivated behavior. A large emphasis of her research focuses on understanding the processes that influence the positive and negative reinforcement and changes in mesolimbic circuitry in order to identify novel treatment strategies for opioid dependence and chronic pain. Dr. Cahill's research is supported by the National Institutes of Drug Abuse, the National Center for Advancing Translational Sciences, the National Institute of Aging, the National Institute of Dental and Craniofacial Research, the Department of Defense, and the Shirley and Stephen Hattos Foundation. So it's my pleasure to introduce our speaker today. And just a reminder, at the end, we will have time for questions. And so there you'll see a box in the lower right-hand side of your panel where you can write in the questions. So Catherine, thanks so much for being here, and we're really looking forward to your presentation.
Okay, perfect. Thank you so much, Chris, and thank you for the opportunity to present today some of my research and also tell you a little bit about the status of the field at the present time about Kappa Opioid Receptors in chronic pain. So there we go. I don't need a title slide. Here we are. So for chronic pain, many members or patients that have chronic pain also have a diagnosis or at least some association of negative affect. So the comorbidity of mood disorders, example, anxiety or depression, can range between 30 to 80% depending on the pain etiology. And this is probably emphasized even more in the fact that chronic pain is second only to bipolar disorder as the major cause of suicide among all medical illnesses, irrespective of whether or not they've actually had a psychiatric diagnosis. So this is a really staggering statistic, and this is what's driving part of my research. And the reason for that is because opioids are effective in alleviating multiple components of the pain experience. So we know that pain is complex. It has both a sensory element, which you could refer to as the intensity of the pain, but it also has an affective component. So whether or not pain bothers you. So is that affective dimension, that emotional experience. So sometimes you can have a low nagging pain and the intensity might not be very high, but it can really bother you throughout the day. And opioids have the ability to diminish both the intensity and that affective component. In fact, opioids really almost can lead to a dissociation from that pain experience. So sometimes you can still feel it and have that intensity, but it doesn't bother you anymore. And this is quite common in post-operative settings in analgesia with opioids and having an analgesic effect there. Now, opioids are also very effective antidepressants. We know that buprenorphine, which is a partial mu agonist and kappa antagonist, has the ability to produce antidepressant effects in treatment-resistant depression. And prior to the 1980s, opioids were even used as antidepressants, except it's no longer used because of their high risk for abuse potential. So there is this conundrum of being able to find effective pain relief, even with the moderate to severe pain associated with trauma or post-surgical pain, and minimizing that addiction potential. So many of you have probably seen these statistics before. I took this right off of the National Institutes of Drug Abuse website. 128 people die every day in the United States associated with opioid overdose. And many of those people that take opioids develop a opioid use disorder or addiction. And we know from multiple studies now that 21 to 29% of chronic pain patients can misuse their prescription opioids. And misuse here is defined as any use that's not as directly prescribed. So if you take more or you don't take it, you take it too close to each other rather than the every 4 to 6 hours, etc. Or if you give it to a friend or you sell it to a friend, all of that counts as misuse. And we also know that many of the people who are heroin users initially misused opioid prescriptions. Now, much of the opioid epidemic, at least in terms of deaths, is related to synthetic opioids such as fentanyl. But we can see that even in even in cocaine and psychostimulant related death is going up. And the CDC has warned that cocaine and other drugs as well are being laced now with fentanyl, which may account for driving up part of this statistic. So this is a study that I wanted to tell you about that was conducted at UCLA a few years ago now. It was published in 2017, where they looked at a retrospective study of patients that had opioid use disorder that were within the hospital at UCLA. So most of the patients were predominantly white. They all had health insurance, so it's a very narrow kind of demographic. But what they wanted to know is, for the people who had the opioid use disorder, did they have their pain first before they got their opioid use disorder at the same time, or they had the opioid use disorder first, or there was no pain at all? And in this particular sample of cohort, and the numbers are quite high here, you can see that the majority of them had pain first. But what's more important for this slide that I want to point out is that, go back, that the majority of those people who had pain first that developed an opioid use disorder also had some type of mood-related disorder, where the majority was associated with depression or anxiety. So that comorbidity of that mood disorder is also probably contributing to the development of that opioid use disorder in the patients who had pain first. So what's the impact of that psychopathology when diagnosed with chronic pain patients? Well, we know now that psychopathology, whether or not it's anxiety or depression or other types of psychopathologies, increase pain intensity. It increases pain-related disability, which is important in quality of life measures, and it also increases risk of opioid misuse. There's also studies that show that comorbidity with psychopathology also affects how analgesic opioids are. So if you take a sample of this study, and I'm sorry, I don't have the reference here, chronic pain patients that with or without psychopathology or diagnosis of anxiety or depression were found to have much less analgesic effects to more IV morphine compared to those who didn't have psychopathology. So not only is it affecting their pain and quality of life, it also is affecting the relief they're getting from typical opioid analgesics. So my thesis and what I'm working on is really under using the guide that reducing negative affect associated with chronic pain should improve quality of life and reduce pain. And this is where my research has taken me in terms of the mesolimbic circuitry in the brain and also opioids, Kappa Opioid receptors. So I'm going to talk a little bit then about this mesolimbic circuitry, specifically dopamine. So dopamine neurons are all found in the midbrain, and the majority are in the ventral tegmental area and substantia nigra. The dopamine neurons in the ventral tegmental area are really important for providing salient value and motivation for that stimulus. And a lot of that is projected, those dopamine neurons are projecting to multiple different brain regions. So they're projecting to the nucleus accumbens, my mouse is frozen, there we go, nucleus accumbens, prefrontal cortex, hippocampus, and amygdala. I'm going to focus on the projections to the nucleus accumbens because we know that dopamine release in the nucleus accumbens is associated with most drugs of abuse, including opioids. So dopamine is also important in, we know, in mood disorders. So in depressed patients, this is just 2-deoxyglucose PET imaging of someone who is a healthy control versus someone with major mood disorder and depression. You can see that there's much less activity in the nucleus accumbens as well as many parts of the brain, but including the nucleus accumbens. And we know that dopamine release in the nucleus accumbens is associated with depressive effects. And we know now that dopamine plays a critical role in pain. So this is another PET study that was done at McGill University quite a number of years ago now, in 2007. It's just an example. But this is a PET study for dopamine using raclopride. And what they're showing is the activity of dopamine in the globus pallidus and caudate putamen in healthy subjects after they're injected with a painful stimulus, which is hypertonic saline. So they get hypertonic saline into the muscle, and that's causing release of dopamine in the striatum area. So in the globus pallidus, caudate putamen, etc. But if you do that same study in fibromyalgia patients, you no longer see this effect. So there's this hypodopaminergic tone associated with chronic pain, and multiple groups have shown this kind of data subsequently. All right, so there was also a study by Irene Tracy that came out in 2012 suggesting that dopamine release, or at least activity in the nucleus accumbens, is also predictive of opioid analgesia. So what they did is they looked at painful stimuli and reward responsiveness. And they found that the magnitude of opioid analgesia positively correlated with the response to painful stimuli in terms of activity. This is now an fMRI study that showed that there were specific activity in the caudate, in the nucleus accumbens, as well as even in the ventral tegmental area that predicted whether or not they're going to respond to opioids, or how much analgesic effects they get from opioids. So not only is dopamine important in the actual pain state itself, it's also predictive of how analgesic opioids will be. So I'm going to just now flip to a little bit of some preclinical literature to support the idea that dopamine is important in chronic pain states, or changes in dopamine is important in chronic pain states, as well as opioid analgesia. So I really like this study. It was done quite a number of years ago, showing that injection of morphine directly into the nucleus accumbens or into the ventral tegmental area can decrease persistent pain. And the pain that they were using in this particular study was the formalin test. So the formalin is a subcutaneous injection of formaldehyde in the plantar surface of the hind paw of a rodent. In this case, it was rats. And that produces a licking, flinching behavior for about an hour. If you inject morphine into the ventral tegmental area or in the nucleus accumbens, you could see this dose-dependent analgesic effect of opioids into these brain regions, which are not thought to be important in specific pain transmission itself. And more important, though, he later went on to show that morphine analgesia in the same test, the formalin test, could be blocked with dopamine antagonist or lesioning of the ventral tegmental area dopamine neurons. So this is this data is showing again the percentage of formalin test analgesia following systemic administration of morphine or saline. So in the control bars, you see nice analgesic effect of morphine that is dose dependent. But if you lesion the ventral tegmental area to destroy the dopamine neurons, that effect was significantly reduced. So in this particular test, morphine is engaging the dopamine system to produce that analgesia. Whereas in phasic tests like the tail flick test, it was found that it had no effect at all. So lesioning this area or injection of morphine into the nucleus accumbens or the VTA had no effect on morphine's ability to alter tail flick tests, so that phasic acute pain, but it does modify behavior that's consistent with persistent pain. So what we do know about extracellular dopamine is that in chronic pain is that opioids fail to cause release of dopamine in the nucleus accumbens that is following systemic administration. So if you take an animal and you put a microdialysis catheter into the striatum of the animal, and specifically into the nucleus accumbens, and you give a systemic dose of morphine, you can see that that causes nice dopamine release in the nucleus accumbens. But if you do the same thing in an animal that's had a nerve injury that induces a neuropathic pain state, you no longer get dopamine release. So there's a hypofunction of dopamine in chronic pain states. And this is also evidenced by electrophysiological studies. So Wren published this study in Nature Neuroscience in 2016, showing that if you look at, again, this is a different model of neuropathic pain, a spared nerve injury model, there's less dopamine in the nucleus accumbens of those animals compared to sham. So this isn't with opioids on board. This is just looking at basal release of dopamine. And then if they recorded neurons, dopamine neurons, in the ventral tegmental area, you can see that in sham animals, this is the normal firing rate, and that firing rate is significantly reduced in the chronic pain state, suggesting that those neurons are not firing as often. And this is quantitated here, where the firing rate of those neurons. So indeed, this is another example of a hypodopaminergic state. Now, this was a really nice study that was published by Dr. Narita in Japan that I really wanted to highlight here. And the study is showing that it's again another, sorry, my phone is going off, peripheral nerve injury, showing that if you stimulate the dopamine neurons that are projecting from the ventral tegmental area to the nucleus accumbens, you can alleviate the thermal hyperalgesia associated with that nerve injury. So what they did here is they directly stimulated dopamine neurons optogenetically, and then looked at hyperalgesic responses in the paw using a Hargraves test. So it's just shining a light on the hind paw. So in these animals after nerve injury, so these are just control sham animals. These are the nerve injured animals. You can see there's hyperalgesia prior to optical stimulation. If you optically stimulate the ventral tegmental area, specifically the dopamine neurons, you completely alleviate that hyperalgesic state. And this is just the control here, where you're not stimulating anything. It's just the control to show that putting a light in there is not going to change the paw withdrawal threshold. And then that recovers 2 hours after the optical stimulation. You see the recovery from that hyperalgesic effect. So indeed, modulating these dopamine neurons is really driving that pain experience. And although I haven't shown the data here, they also stimulated the terminals of the nucleus accumbens and got the same effect. So we know that it's the projection of the dopamine neurons to the nucleus accumbens and not to other parts of the brain that were primarily driving that anti-hyperalgesic effect of the optical stimulation. All right, so this just is just a reminder to show you that normally in the ventral tegmental area, you have this tonic release of GABA that is controlling the activity of dopamine neurons. Okay, so GABA is being released and activating a GABA receptor. It can be GABA A or GABA B, and that controls the amount of dopamine that's being released. Opioids produce their I did something wrong here, but that's okay. I'll go back. Opioids cause dopamine release by disinhibition of these GABA. So you have mu-opioid receptors on the terminals of those GABAergic neurons in the ventral tegmental area that then causes GABA release to be inhibited, and therefore dopamine neurons fire. And this is just an example here. Damgo is a mu-opioid agonist. You put it into the ventral tegmental area, you get nice dopamine release that can be detected in the nucleus accumbens or in many parts of the brain where those dopamine neurons are projecting. Kappa receptors, on the other hand, are actually on the dopamine neurons themselves. And in the nucleus accumbens, they're found on the terminals of those dopamine neurons. And here they're producing the same kind of inhibitory action, but because they're on dopamine neurons, they're actually suppressing dopamine release. And this is, I just did the animation wrong there, I'm sorry. So what do we know about kappa opioid receptors and affect? So we know from human studies that kappa opioid agonists can produce anxiety, discomfort, agitation, depression, and dysphoria. And we primarily know that from the ingredient in salvia, the plant salvia called salvinorin A, which can be abused, but it does produce a lot of negative effects. We know that the endogenous ligand in the body that activates kappa opioid receptors is increased in the striatum or caudate putamen of human suicide victims. And we also know that dynorphin is increased in the nucleus accumbens and caudate putamen during withdrawal of many different drugs of abuse, including alcohol, cocaine, and indeed opioids as well. So kappa opioid receptors may be a potential target to mitigate or attenuate pain-induced negative affect, and that's what I'm going to spend the rest of my talk or time telling you a little bit about. Okay. So there are many studies that are there out in the literature talking about how and demonstrating that kappa opioid receptor activation within mesolimbic circuitry can produce this negative affective state. So in the ventral tegmental area, those dopamine neurons are projecting to many, many different parts of the brain, the hippocampus, prefrontal cortex, nucleus accumbens, and amygdala. And we know that there are kappa receptors in many of these different brain regions. Some we know that are specifically on the projections. Some we're not really sure exactly if they're on that projection itself, or it's just kappa receptors in other neurons within these areas that's producing the negative affect. But you can see that if you give a kappa agonist into the ventral tegmental area, there's data showing that it produces dysphoric-like effects, so it can produce a condition place aversion. We also know that even modulation of serotonin neurons can produce that dysphoric state or aversive state. And we also know that specifically activation of kappa receptors in the nucleus accumbens also can drive those mood-related affective disorders such as depression and anhedonia, or in this case, most anhedonic measures are through intracranial self-stimulation or with sucrose preference measures. So one of the aspects that we can look at from whether or not this has any validity in clinical populations is looking at Suboxone or buprenorphine. So buprenorphine is a mu partial agonist with kappa antagonist properties, and Suboxone is buprenorphine combined with naloxone. So you have the naloxone is blocking that partial activity of at the mu opioid receptor of buprenorphine. So you're only left with the antagonist properties at opioid receptors. Oops, sorry. So here was a study that was actually conducted, I can't remember if this one was I think this one was in Israel. And this was a chronic pain patient group that had significant suicide ideation. And they gave buprenorphine, very low dose, 0.1 milligrams titrated to 0.44 milligrams as a lollipop. And they did a study over 4 weeks and found that buprenorphine significantly reduced suicide ideation in these chronic pain patients. And as I mentioned, these were not patients that had an opioid or any other substance use disorder. So showing that buprenorphine was really effective, not only in probably relieving pain, but also reducing that suicide ideation. There's been a couple of other studies that I wanted to highlight as well, specifically looking then at the combination of buprenorphine and naloxone being able to decrease pain. So this was a study out of Sandy Calmer's group out of Columbia, showing a 7-week inpatient study. where they took chronic pain patients that had a history of opioid abuse and transitioned them to buprenorphine naloxone. And at the highest ratio dose that they looked at, which was 16 milligrams of buprenorphine of naloxone, those patients actually had significant pain reduction compared to the lower dose of buprenorphine, but certainly compared to what they were, their pain ratings on their other opioids. Most of them being on oxycodone. Another study that was conducted, a clinical trial, again, just small patient group of only 54 participants, but these again were chronic pain patients with opioid addiction, randomized to either methadone and buprenorphine naloxone, and in both cases, either treatment significantly produced analgesia in the participants with chronic pain and opioid addiction. So there's some evidence that kappa antagonist properties is probably contributing to this because of the fact that there's a lot of kappa antagonism in buprenorphine itself. All right. And then this isn't a chronic pain study, but going back to a preclinical study, and these were just to show you that the negative affect associated with administration of heroin can also be recovered with a kappa antagonist NORBNI. So they can either prevent the negative affect as demonstrated by a lack of social interaction between mice, or they can reverse it. And this was a study that was published by Lutz who studied with Brigitte Kiefer. So I'll now just show you some of our data with Kappa Opioid receptor and modulation of Kappa Opioid receptors in chronic pain. So the first thing we wanted to know was, is there actually an increase in function of the Kappa Opioid receptor in chronic pain states? And the model that we're using is the loose ligation of the sciatic nerve with a polyethylene cuff. And in this model, you get significant allodynia associated with mechanical stimulation. We don't really see very much with the thermal, at least warm thermal. We do get a cold allodynia. But associated with this model that's been published by many groups now is that they start to develop this affective-like behavior beginning about 4 weeks after induction of chronic pain. So initially you see kind of anxiety-like symptoms with novelty suppressed feeding, Marble-Berry light dark, and then that follows with depressive-like symptoms that you can test with forced swim test, tail suspension, etc., or in this case, they also used a splash test. So kappa, one of the things that kappa agonists we know do is produce condition place aversion. So that was one of the ways I assessed whether or not kappa activity was enhanced in chronic pain state. So I want to just spend a few minutes to talk about a condition place aversion. So this is the typical apparatus where you have contextual cues, whether or not it's visual in the boxes themselves, as well as tactile on the floors. Sometimes there's odor, but you have cues in 2 different compartments that are different from each other. But otherwise, these boxes are identical. So an animal is placed in the center and it can go in one side or the other side. And during conditioning, you close the little guillotine bar door here, and you allow the animal to experience vehicle where he's left in this compartment one day, and then on a separate day, you give a kappa agonist. And if you do this over a number of days, and then you put the animal back in a box to look at whether or not where he's spending most of his time, he's going to avoid the chamber where he got the kappa agonist. So kappa produces this conditioned place aversion where they're going to spend all of their time in the vehicle compartment on that post-conditioned test. And this is just a heat map of some of the data we've obtained showing, in fact, that the animal is really spending all his time in the vehicle compartment and not in the side where it got the kappa agonist. In this case, it was U50-488. Now, kappa agonists can produce a conditioned place aversion when injected into multiple different brain regions, including the nucleus accumbens. There are some that we know it doesn't do it, like the dorsal striatum or the substantia nigra. And importantly, if you block kappa antagonists, though, you put kappa antagonists in the prefrontal cortex, or you delete kappa antagonists in this area, or the dorsal raphe, including the ventral tegmental area, and that projects to the nucleus accumbens specifically, you can block kappa aversion following systemic administration. So there's multiple areas in the brain where that kappa antagonist is probably producing its place aversion effects. So this is our design, and this is what our boxes look like. So we can make them either 2-chamber or 3-chamber. So this is our neutral compartment where they go out here and go in the other side to go to the different compartments. We do habituation preconditioning. We condition over either 6 or 8 days, and then they're tested in a drug-free state. And we do this in both the naive animal that hasn't had any manipulation at all. We do it in sham animals that have had probably some post-surgical pain due to incision through the skin and the muscle. And then we have the peripheral nerve injury animals. In our male mice, we see that there's significant place aversion being enhanced in the chronic pain state compared to the sham or the naive group. But interestingly, we did not see this in the female animals. So really this enhanced place aversion following systemic administration of the kappa agonist was sex specific. And we know that there's lots of different sex dimorphism in kappa-mediated analgesia as well, that we can that I'm not going to talk about, but if you want to know more, we can discuss it in the question period. So when there's chronic pain on board, we see an increase in kappa function as evidenced by the conditioned place aversion in the male animals, but interestingly not in the female animals. All right, so I already mentioned to you, so what about dopamine? So I talked to you about, before I showed you this data showing that opioids don't cause release of dopamine in the nucleus accumbens when in a chronic pain state. So what about kappa opioid receptors? Can kappa antagonists recover this? So in collaboration with Ann Andrews' lab at UCLA, we were able to show that indeed JD-TIC, which is a selective kappa antagonist, can recover opioid-induced dopamine release in the nucleus accumbens in that chronic pain state, suggesting that there is an increase in kappa activation on those dopamine neurons that's responsible for the loss of opioid-evoked dopamine release. So then we went on to just ask, well, if there's an increase in function, is that related to simply an increase in receptor expression within that circuitry? So I'm not going to show you all of the data, but I will show you the data that we looked at in the ventral tegmental area. So looking at transcript or mRNA in the ventral tegmental area by either RNA-scope or quantitative RT-PCR, we see that there's a significant increase in the expression of mRNA, Kappa Opioid Receptor mRNA, in the ventral tegmental area of male animals, but not so much in the female animals. And here's just the white is the kappa the red is dopamine neurons, the green is GABAergic neurons, and you see most of that increase in kappa is actually within the dopamine neurons and not on GABAergic neurons. And here's just the quantification of the kappa receptor expression. We also took brain slices that included the ventral tegmental area here and the substantia nigra, and we exposed them to GTP gamma S autoradiography in the presence or absence of a kappa ligand. So here we have, I'm showing you both the male and the female data, the sham animals on top, the neuropathic animals just underneath, and there is a significant increase in kappa stimulation of GTP gamma S in the chronic pain state compared to the sham and the naive animals. But again, we see this really significant sex effect where this is primarily driven in males and not so much in females. And this is published now. This is Journal of Neuroscience 2019. So can kappa antagonism alleviate the sensory and affective dimensions of chronic pain then? So the first thing we did was to look at the negative affect associated with that chronic pain state. So I told you that negative affect usually develops between 4 to 8 weeks after. We did a light-dark test, which is really kind of a measure of anxiety. So animals really like to stay in the dark compartment. They don't like to be in a light compartment. Under a normal state, 30% of their time is in the light, the rest of the time is in the dark. But if you give them an anxiolytic agent, they will spend more time in the light. So that is indicating that it's producing this anti-anxiety drug. In chronic pain animals, they actually have spend more time in the dark. So they are showing this anxiogenic effect in the chronic pain state. So here we took animals and we treated them with either saline or JD-TIC and performed this test. And we see that JD-TIC significantly improves the amount of time in the light, suggesting that it's relieving that negative affect associated with chronic pain. But interestingly, this effect was found not just in the males, but also in the females. We got a really nice anxiolytic effect in females as well. So in these tests, we have an effect that's happening in both sexes. We also looked at a test of depression, which is the forced swim test. So the amount of time the animal is immobile is a sign of depression. So we see that there's a significant increase in the amount of time immobile in the chronic pain state, and that is significantly blocked by pretreating animals with the kappa antagonist prior to the study. And interestingly enough, this also happens in the female animals, where there's a significant difference between saline and JD-TIC administration in the females. So again, no sex effect on the negative affect state, which is quite interesting. So I want to show you a little bit of data from Nico Masoli at WashU in the lab of Jose Moran Concepcion. And I was a collaborator on these studies. I did some GTP gamma S for them, but I wanted to show you this because this was also measures of negative affect in the context of sucrose self-administration. So the model was different. They didn't use a nerve injury model of neuropathic pain. They used a chronic inflammatory model induced by complete Freund's adjuvant in the hind paw of the mouse or the rat. They did both species. And here they're just looking at how much an animal will work for a sucrose reward pellet. So for FR1 is they get 1 sucrose reward for 1 lever press, and then here they jump to 2 lever presses for 1 reward, and then 5 lever presses for 1 reward, and then they take the animals through this progressive ratio test where the number of reinforcers earned goes up with the number of lever presses. So they have to work harder and harder and harder to get that sucrose reward. So they do a progressive ratio test in the animals prior to injection of norbNI, which is that kappa antagonist, and then they do a baseline with the kappa antagonist on board prior to the pain, and then they do the pain. And the data here just shows that the kappa antagonist really didn't have any effect on the progressive ratio or the number of sucrose reward in the absence of pain, but the presence of pain depressed their producing kind of this anhedonic response for the sucrose reward that could be recovered with the kappa antagonist. And not only that, they also then show that if you inhibit dopamine neurons in the nucleus accumbens shell, that was driving a lot of that behavior. So the dynorphin that was activating those kappa receptors, sorry if I misspoke and said dopamine, dynorphin neurons were activating those kappa receptors on those on dopamine neurons, and they did this through DREADS. So they inhibited the dynorphin neurons and show that if you inhibit those neurons, you significantly recover that depressed sucrose reward activity in the chronic pain state. So we know that kappa antagonists do not alter sensory thresholds in our chronic pain state, and we've shown that. So here's just mechanical allodynia associated with nerve injury, and the kappa antagonist does not block that. I'm sorry, I'm running out a little bit of time. I didn't time this so well. Just want to show a couple more slides, Chris, and then I'll stop. Other studies by Frank Pareca's group also show the same thing. So a kappa antagonist doesn't do anything to the sensory thresholds, but it does produce this, relieves the tonic aversive component of chronic pain. So in this case, they used a condition place preference to gabapentin, showed that you had a place preference to gabapentin, but if you pre-treated the animals with the kappa antagonist, you no longer got that effect. So the interpretation here is that kappa antagonist is blocking the motivation to seek the gabapentin. So if you take the negative affect away associated with chronic pain, they no longer care about the gabapentin compartment. We did the same thing, but we used actually morphine. So morphine produces a place preference in both the sham animals as well as the neuropathic pain animals. And if you give a kappa antagonist to the sham animals, they still want to go to that morphine compartment. But if you give it to the pain animals, you block that place preference, suggesting that the drive and motivation to seek that morphine compartment was related to the negative affect associated with pain. And if you block that with the kappa antagonist, you no longer produce that effect. So this is the last slide just to show you that the kappa antagonist properties also can modify the negative affect of ongoing pain. So in this case, we used kind of a novel single chamber condition place preference. So the animal was made neuropathic or not, treated with a kappa antagonist that produces, this is a kappa antagonist that has very long lasting effects, JD-TIC, and then they're conditioned to they're conditioned over a series of days to either just receiving injection of saline and put back into their home cage, or they're confined to one of the compartments of the condition place preference apparatus. In both cases, whether or not it's male or female, you see that the animal, after the conditioning during the post-conditioned state, they associate their ongoing pain with that compartment. So there's a place aversion to where the animal was conditioned, okay? And then, but if you then treat those animals with JD-TIC prior to the conditioning, you no longer got that place aversion. So that kappa antagonist is really blocking that negative affective state or that tonic aversive component of the pain state. But interestingly, it did not block it in the female animals. So we have this separation then between the typical affective states of anxiety and depression versus that kind of pain-related negative affective state. We also, in collaboration with Tuan Trang at University of Calgary, did some studies with a different pain model to look at the generalization across labs, as well as a different type of pain. In this case, it was that conditioned or complete Freund's adjuvant. And again, they treated the animals with vehicle or JD-TIC and found that indeed JD-TIC, that kappa antagonist, blocked that place aversion to just being conditioned to a chamber where it can experience ongoing pain. There was no stimulation here. So Chris, I think I'll stop there. I just had a few more slides, but I think in the interest of time and to take questions, I think we should stop there. Just to say that we also did some studies to show that if you knock out kappa receptors within the ventral tegmental area, we could also alleviate this tonic aversive component of pain. So we know that it was kappa receptors on those dopamine neurons that's primarily responsible for the alleviating effect of kappa antagonists.
Okay, Catherine, thank you so much for an excellent presentation. And we do have time for questions. If you have a question, you can write it in the box in the lower right corner of your GoToWebinar panel. And while those questions are coming in, I have a question or two myself. So I'm just wondering, how long does the kappa antagonism last? Like, I'm wondering if there's some kind of upregulation of kappa receptors over time in the presence of antagonists.
So the kappa antagonists that we've been using in this study, NorBNI and JD-TIC, have really long-lasting effects. So they can last anywhere between 2 and 3 weeks in a normal, healthy animal. And we know that that's the case even in cell culture. And Charlie Chafkin at University of Washington has done a lot in terms of the mechanism underlying that. But we've shown that at least in chronic pain states, that antagonism only lasts about 4 days. So whether or not it's due to just a change in the signaling of the kappa receptor, or there's actually an increase in the turnover of the kappa receptor in chronic pain states or an upregulation, the kappa antagonist does not have that long-lasting effect. Now, I don't think, if I remember correctly, I don't think a single injection of a kappa antagonist, even though it has that long-lasting effect, has dramatic effects on changes in transcription of the kappa receptor. But in this case, it's not really applicable in the chronic pain state because it really doesn't have that long-lasting effect anyway.
Okay. All right, thanks. So we are getting some questions from the audience. One is, are microglial cells involved in the dimorphic effects of kappa opioid receptors?
So we don't know that. That's something we'd really like to know. So we've done a lot of stuff on neuroinflammation as well. And we know that neuroinflammation, specifically even within the ventral tegmental area. So if you have a peripheral nerve injury, you have neuroinflammation at the level of the spinal cord, but you also have neuroinflammation, at least in terms of reactive microglia, showing up in mesolimbic brain structures, including the ventral tegmental area. We've shown that if you one of the consequences of that neuroinflammation is a greater inhibitory tone on dopamine neurons. So there's a change in the amount of GABA released from those GABAergic neurons in the ventral tegmental area that increase a GABA tone, inhibitory tone on those dopamine neurons that are expressing the kappa. But in terms of whether or not neuroinflammation is driving changes in kappa receptor is really not known, except for a study that Charlie Chafkin did probably a decade ago now, showing that there's kappa receptors on astrocytes, and that expression is increased on astrocytes, at least at the level of the spinal cord following peripheral nerve injury. But we don't really know how neuroinflammation may alter kappa receptor expression in chronic pain states, especially in the brain.
Okay. Here's another one. Is long-acting KOR antagonism unique to NOR, BNI, and JD-TIC, or generally applicable to all chemical classes of KOR antagonists?
So there's lots of new development of kappa antagonists that are short-acting, which is primarily, where drug development is going. You don't want something that's necessarily so long-acting, because you want it to be able to be reversible. So it's not applicable to all kappa antagonists, but certainly there are short-acting antagonists that are being developed in clinical study, for clinical studies as well as for research.
Mm-hmm. Okay. What is your opinion on the viability of biased KOR agonists such as 18-methoxychloronaridine on the treatment of pain?
So I think that's really, I would love to get my hands on it. I have tried some short-acting antagonists in our studies to see if I could get a place preference in a chronic pain state, and I wasn't able to get a place preference with a short-acting kappa antagonist. But in my hands, those kappa antagonists, it's interesting because I think the distribution, at least the ones I had, the distribution into the brain may not have been the same as our typical antagonists. So it was able to block kappa-mediated analgesia, presumably at the level of the spinal cord, but it wasn't able to block the kappa associated hypolocomotion. So I'm not sure it was actually getting into the mesolimbic circuitry to actually produce the effect. But I'd be really keen to do some work with those other short-acting antagonists.
Okay, more questions still coming in. Does buprenorphine's abuse liability fully come from mu opioid and agonism, and kappa receptor is not involved in or inhibit it?
So the abuse liability with with buprenorphine is driven by the partial mu agonist, not by the kappa antagonist properties. Buprenorphine is also a delta antagonist, not just a kappa antagonist, but it's we know more about its kappa antagonist properties than its activity at the delta, but it's certainly driven by the partial mu agonist activity.
Okay.
If it was the case that it was kappa antagonist, then you would see abuse liability with Suboxone, and I don't think there's any good evidence that there is abuse liability with Suboxone, which is the combination of buprenorphine with naloxone.
Okay. There's a question about the sex differences you talked about. Do you think that the multiple sex differences in kappa receptor activity are due to chromosomal differences, different organizational effects of sex hormones, or different activational effects of sex hormones, or a certain combination of those effects?
I think it's probably a combination. So there was a study that was conducted at UCLA by Anna Taylor, who's now at University of Alberta in Canada, in collaboration with Art Arnold, using 4 core genotypes. And in this case, they were just looking at acute effects of kappa agonists at being able to produce antinociception in phasic pain tests like tail flick test. And these mice, these 4 core genotypes, have the ability to differentiate sex from hormone because they have female genetics with male gonads and male genetics with female gonads, so they can really differentiate this. And in their hands, at least, it seemed to be a combination of both, that it was both genetic and hormone.
Okay, thank you. The short-acting molecules also antagonize mu to some extent. What do you hypothesize would be the effect of mu antagonism in these models.
So mu antagonism, at least with naloxone, you get a place aversion. You get a place aversion in the naive animals, you get a place aversion in the chronic pain animals. We did an interesting study where that naloxone aversion is primarily driven by endogenous enkephalins. So if you do these experiments in an enkephalin knockout where they normally don't show a place aversion, naloxone, interestingly, switches from being aversive to rewarding. So this is hard to describe without a figure in front of me, but imagine you have an animal that has no enkephalin to drive the naloxone aversion. You make that animal neuropathic, and then you do a condition place preference with naloxone to see if it's still producing an aversion. Well, you don't even get just no aversion. You actually get a place preference. So blocking mu, delta, or kappa without the enkephalin to produce the aversion, blocking the enkephalin effects, is producing a place preference. The pain animals want to go and like that compartment. And we were able to show that you could block that with JD-TIC. So definitely you can switch naloxone from being aversive to rewarding by blocking kappa.
Okay. We do have more questions. What is the role of 5-HT in the affective component of neuropathic pain?
Great question, and we really I don't know a lot about serotonin in chronic pain states except for what's happening in the descending circuit. So we know that serotonin from the RAFE and RVM are projecting down to the spinal cord as part of that descending noxious inhibitory control. But how serotonin is modifying pain responses in the brain is really unexplored.
I'm also wondering, as far as human translation, are you aware of any important differences between rodents and humans as far as these pathways are concerned?
In terms of the mesolimbic circuitry, you mean? Is that what you mean?
Well, yeah, just as far as drug discovery and whatnot.
So I think
some of the models.
I think these models are actually really well validated for human translation. I think the fact that we can modify, in fact, it's my kind of hypothesis that the negative affective state and tonic aversive state of chronic pain is probably a better predictor for translation than just looking at the sensory component and the especially threshold evoked pain responses.
Okay, I think we'll take one more question from the audience. Do delta receptors effects also differ from mu or kappa regarding pain control or abuse liability?
So there's really some nice data about delta opioid receptors not having any rewarding effects on their own, and only we published some stuff showing that the delta agonists produce a condition place preference, but only in a chronic pain state. And there's some older data suggesting that delta agonists were kind of rewarding or may have abuse liability simply because if you take delta away, you lose some of the rewarding effects of morphine, at least in a condition place preference. But we now know that delta in the hippocampus is really important for learning that association. So it wasn't really the rewarding effects itself. It was delta's involvement in being able to learn the contextual cues with the drug experience. So we know that that's the case. So I think there's some really good evidence that delta receptors are effective in chronic pain states. The only thing that still has held up a lot of delta translation is is partly due to their some of their agonists having seizure effects and convulsive effects. I'm not really sure exactly where things are in terms of translation in clinical studies. I know some delta drugs have failed in clinical trials, but there's certainly more stronger evidence that they may be good antidepressants as well. So I think maybe we just haven't looked at the right pain outcome in clinical studies yet. We probably shouldn't be doing things like dental pain, but really looking at things that are quality of life measures and affective dimensions of chronic pain with delta agonists.
Okay. Well, Catherine, thanks again for an excellent presentation. Thanks to everyone in the audience for participating and asking great questions. I'd also like to thank AnaBios' Director of Marketing, Gary Watkins, for putting this together. And just a reminder to everyone, our next pain webinar will be in January 14th, with Dr. William Renthal at Harvard University. He's a collaborator of Clifford Wolf. And the title of that presentation will be Flexible Identity of Peripheral Sensory Neurons After Axonal Injury. So thanks again, everyone, for joining. Thanks, Catherine. We wish you all a great Thanksgiving, those of you in the U.S. Bye for now.
Perfect. Thanks, everybody, for attending.